Good morning. I don't know if you can hear me or not. Can you hear me okay? Can you hear me? Okay. So the calendar was for the invite to start at 11, but the actual meeting starts at 11:30. So we've got a half an hour. You're welcome to stay on or hang out, whatever works for you. But I wanted to give you that update.
Okay, thank you.
Recording, and it doesn't today, so I just wanted to confirm that. Oh, it does today? It does now say recording.
I just
it does
turned
now.
on now. Thank you.
It does now. Okay,
Yes.
Thank you so much.
Thank you. And if you could please stop your video now.
So welcome again, and I'd like to start a conversation about intervention and treatment. I invite you to chat questions that you have at the end of the presentation. I'm going to try and leave some time so that we can address those questions. The first thought that I'd like to leave with you about intervention and about initiating the treatment process is that all of our efforts in this direction have to come from a place of love. I talked briefly yesterday about not engaging in the process if you're still involved in the anger. I understand completely that the people that you are likely struggling with are disruptive, and they do things that are irritating, that they're upsetting. They make it difficult to love them. But this process only can be successful when we come at it from a place of love, when we take the time to step back and make sure that all of our actions are based in that, and that we find other outlets to vent our frustrations, so that the time that we're with the people that we're trying to help, those things all come from a place of love. I'm going to go through the questions that over the years I have received about what an intervention is about, and what my screen advanced without my help. So to talk about the questions that I have, there's no way that to do an intervention is a very, I'm doing something incorrect here, but we'll see if I can get that slide to stay where it belongs. Interventions are complicated. You're already getting the sense that I am not the most technologically savvy person in the world, because I'm not able to get my screen to do what I want it to do. I'll try one more thing. Hopefully that will do it. Nope. This is beginning to be a little bit like a comedy show. At any rate, you'll have copies of the slides when I'm finished with my presentation. But I'm going to go through the questions that people most frequently ask about doing an intervention. And the first question that always comes up is, how do I know if the person that I care about has an addiction problem? The easiest answer is that you frequently end up seeing people do things that just absolutely positively don't make sense. They're doing things that are disruptive. They're doing things that they promised that they wouldn't do. They do things that make you question whether you're the one that's going crazy or whether they're the ones that are going crazy, or what it is that's going on. And so in the initial part of talking about whether or not you want to do an intervention, the suggestion that I have is that you share your concerns with the people around you that you trust, and that you know that they have access to the information as well, that you form a circle of safety with other people who are likely to have good judgment, and you try and understand why this behavior is happening. But when people have these kinds of behaviors that just absolutely positively don't make sense, it is very helpful if you can form that circle of safety, if you can have a group of people that you're willing to share the information with, and to see whether what you're doing seems to make sense. The next question is, and this is the one that's always hard. There's this idea that people have to hit bottom before they're able to get help. And the way that I most frequently explain this is to say that intervention is about raising people's bottoms. Intervention is about how we let other people know that their behavior is disruptive, that their behavior is not acceptable, that their behavior is causing problems with the people around them. And until we do that, we're preventing people from experiencing their bottoms. We're preventing people from experiencing the consequences of their behavior. Many times in communities and in congregations, there's this wall of silence, that we're afraid to approach other people. We're afraid to let them know just how disruptive their behavior is. Or when we do it, we only do it out of anger. And both of these scenarios are incredibly disruptive, that they prevent people from having an honest look at what kind of problems their behaviors are causing. And that really is what an intervention is about, is to let people know that they're disruptive and that their behavior just isn't acceptable. One of the other real myths about addiction is that somebody has to want help in order for them to get help. If we waited for people to want the help, for the most part, they'd never get it. We have to be in a place where we help them to understand that they need help, because they really are in denial about what's happening in their lives. They're in denial about how disruptive it is. They're in denial about how badly they're hurting themselves. The process of intervention is to get somebody to a treatment center where a trained staff can help them recognize the need for help, because they're very unlikely to arrive at this on their own. The next myth that's really common as I talk to people about how to do an intervention is that there's this myth that treatment doesn't work when someone is forced to accept help. Hazelden, probably the longest term provider of addiction treatment centers, did a study a number of years ago. And one of the really interesting things that they found out was that regardless of whether people were forced to come to treatment or whether people volunteered to come to treatment, there was no difference in their outcome. That the process of being in a treatment center, of working with professionals and going through the process One of the things that has to happen is that they overcome all of the objections that people had to being in a treatment center. And that really is very crucial. It's part of the therapeutic process. You hear a lot about denial with addiction, and there's absolutely no question that level of denial that people have is one of the things that makes them not want to accept help. But when they arrive in a nurturing treatment center and professionals start to work with them, we can change that. That's something that we do with a real, just as an integral part of the regular treatment that we do. The next question / myth is around, is it all right to intervene on a senior citizen? Mary Jean addressed this really eloquently yesterday, describing the 92-year-old that somehow still figured out how to get to a casino in order to gamble. Somebody that has the wherewithal to figure out how to drink or to engage in any other of their addictive behaviors also has the wherewithal to participate in treatment. I have to assure you that as part of the treatment process, one of the things that we do is make sure that people are cognitively intact enough to be able to participate in the treatment and to benefit from it. If it turns out that they're cognitively impaired and can't, then we absolutely will alter our plans for what we want to do. But if people are cognitively intact enough to engage in the behavior, they can really likely benefit from a treatment and from an intervention. One of the ways that I talk to people that are struggling with this is to say, one of the things that we're trying to do is to preserve people's dignity, that as they age, we don't want it to be that the only thing that they're remembered for is the addictive behaviors that they had later in life, because sometimes those overshadow all of the good ministry and all of the good work that they did earlier in their lives. And we're remembered for the end instead of all the good things in the beginning. And a treatment process, even later in life, helps a person to do that. And it helps to make sure that the latter part of their life has as much meaning and dignity as the beginning of their vocation did. How many people do I need for an intervention? Complicated question. The short, easy answer is that it's not something that you ever want to do by yourself. I would say the minimum number is 3, and I really like to see around 5. I don't like myself, I don't like going over 5 because it really feels like when a person comes into a room with 10 people in it, that it's that they're being ganged up upon instead of being intervened on. So you look for that magic number of people. It's not an exact science, but if you do some good discernment around this and try and find a group of 3 to 5 that have an investment in the right attitude, that usually works very well. Another common question that I get is whether or not you have to have a professional interventionist. And one of the pieces that I would offer to you is that Guest House provides an interventionist whenever you'd like one. Mary Jean is trained in this. I'm trained in this, and Chris Stark is a trained interventionist. We send an interventionist to you, or we'll have an interventionist consult with you at no charge. This is not a service that we charge for. You have the ability to access all of our expertise free of cost anytime that you need it, and we're available to do that. What do you do if people are opposed to doing the intervention? What happens if not everybody in the community or their congregation is on board with doing this? And my opinion about that is that opposition almost always comes out of a sense of not having enough education about what an intervention and what treatment are. Is that people need to have a better understanding of what the problems are, and they need to have a better understanding that the intervention is an act of love, and that what we're trying to do is to help people. There are times and places where there are people that are still absolutely opposed, and they need to be excluded from the actual intervention process themselves. They're not somebody that you want to have in the room while you're trying to do that. Anybody that's in the room to do the intervention really needs to be on board with the whole process. There's this myth that people will walk out of an intervention, and one of the big objections is that there's going to be a blow up, and the person's going to storm out of the intervention. I've been doing interventions for almost 30 years. Before all those ridiculous television programs went on about how to do interventions, and it became a sort of a drama, I never had anybody walk out of an intervention. It just didn't happen. After it showed up as a reality TV show, and people started to think, well, that's what the norm was, is that you had to have these kinds of temper tantrums, and you had to storm out. But even since then, it's still very, very rare. And as you prepare for how to do the intervention, there's some strategies that you have about what you're going to allow and what you're not, and who's going to go out and ask them to return, and how to do that. So if you have a well-planned intervention, you will have already accounted for all the steps that are necessary to take care of that. The next question that I frequently get asked is, what happens if there's a sort of a debate or an argument during the intervention, and how do you deal with that? There again, this goes back to a strategy of how you professionally prepare to do an intervention. It's really important to have talked about how you want to do this. And as I describe it for people, one of the things that I say is that this is not the debating society. If everybody on the intervention team has prepared what it is that they want to say, and they're prepared to talk about it, they need to make definitive statements, and we're not going to go back and forth about whether or not that happened. If you start to argue with the alcoholic or the addict or the person that you're struggling with, you will lose control. So we avoid doing that, and having somebody trained in facilitation that's able to cut that off is really an integral part about how we do that. Especially with communities and congregations that are spread across the country, one of the difficulties is that not everybody can be there to do this, that it's hard to get a group of people together because everybody lives so far apart. A year ago, I would have told you that a Zoom intervention was not an effective way to do an intervention. All of my thinking about that has changed completely in the last year. We've had numerous very successful Zoom interventions. I think that they can be very effective. It requires a different kind of facilitation, but technology really is working in our favor today. It's working in our favor in a way that we weren't able to do that before. If you set it up properly, the distance between people doesn't really appear to make a lot of difference. The last question has to do with what happens if the person that we do an intervention on and send to treatment, what happens if they have a relapse? How do we address that? And I would tell you that the easy answer to that is that when you get ready to do the intervention, you decide how you as a group are going to respond to this person and what their consequences for not complying with the intervention are. I think it's really important that you have consensus among everybody involved, and that if somebody leaves treatment and relapses, that you fall back on what you said you were going to do, that you enforce the consequences that you talked about before you ever did the intervention. That those decisions were already made, and that you don't second guess yourself and change them. Mary Jean, you have anything you want to add to this discussion? Mary Jean has done far more interventions on women religious than I have, so.
No, Jeff, I think you've done a fine job. The only thing I would add is that it is a circle of love. And the person at the time may not experience it that way, but you who participate in it, that's one of the reasons to have a group of people and not do it by yourself, so that you really know what went on at the intervention, and you know within yourselves that the truth spoke, and it was spoken in a calm and caring way. If you do it by yourself, one of the things the person does, it's the disease speaking, is point out all your flaws and explain how awful it was to anybody who will listen. And then if you have no one to bounce that back off of, you do question yourself and you do second guess it. So I second Jeff's advice. Always have someone else present, and ideally, not ideally, but minimum of 3. So that's really all I have to add. Thanks, Jeff.
Thanks, Mary Jean. I'm really stubborn, so I'm going to attempt to restart this this PowerPoint presentation and see if I can have my visual aid in front of me as I do that.
You had it working the last time you had it up, Jeff.
All right.
And then if you go to the bottom right, after you get it launched up, you can put it on the, now bottom right, if you go over to the little presentation icon, it'll fill the screen. No, bottom right, bottom, down, down, a little bit lower, left, left, left. Click, right, whoop, click, no, to the right, one more to the right. Click that. Oh no, that's not what we wanted.
Can you see this?
Yes.
All right. On the screen is access to a website that Guesthouse has collaborated with the It's called gethelpgivehelp.info. They are an incredibly helpful organization. It is a collection of videos and self-help information about how to work with somebody, how to set up an intervention. There are short videos on absolutely every aspect of how you want to do this. It's very useful. You can refer people to it. You can have anybody that you're working with, members of your team, other members of your community that are struggling with how to get their head around this. There are almost 100 hours of little videos on every single aspect of how to do this. I would, if you have any questions about how to complete an intervention or to get ready to do one, this is the resource that I ask everybody to have a look at. All right, I want to move to talking about the rest of what treatment's about. There are 6 distinct stages of what happens when somebody arrives at the treatment center. The first one really is taking a look at their potential for withdrawal. We want to make sure that everybody that arrives at Guesthouse stays safe. And if they've been involved with any chemical and with some of the other mood-altering behaviors, there's a series of medical syndromes that show up, some of which are very, very life-threatening. And we want to make sure that as they come in, we address those. Primary treatment starts off with a complete evaluation from our medical director and our nursing department. We want to make sure that everybody's physical health is stable. Frequently, the people that we get, the addicts and the compulsive overeaters, have multiple health conditions that are not well managed. Diabetes, high blood pressure are probably the two most significant. And we spend a lot of time getting people stabilized. If those medical conditions are too uncontrolled, it's almost impossible for people to focus on the treatment process when they get here. And so the first 3 or 4 days really are almost entirely medically oriented. We want to spend our time making sure that people are stable and that their health conditions do not become the overriding focus of their attention. After we're completely sure that those medical conditions have been stabilized and addressed, we move into the more primary treatment part of it. We want to start the assessment process from the addiction standpoint. We want to establish what exactly were the consequences and the implications of their addictive behavior. That involves contacting the referents. It involved contacting the concerned others in people's lives and making sure that we have a complete understanding of what it is that was causing people to get the attention of their community in the first place. It's really interesting because as I do the intervention and I talk to community leaders about the person, I get this list of things that has happened, and then the intervention's over and the client comes to treatment, and I get a completely different story from them. They generally don't see the problem. They generally don't understand what the consequences of their behavior were. They don't understand the complications. And in order to move forward with the assessment and understand what's going on, we have to clear up these discrepancies. We need to have a shared consensus between the referent and the client about what it is that's going on. And that's a complicated process. Frequently, we have to have clients write letters to people that they trust and ask for for the concerned others' impression of what it was that was going on in their lives, and then use the therapeutic process to reconcile that. That denial of what it is that's happening is the core of all addiction treatment. That you don't really make headway with clients until you get them to see that their view of the world is not the same as what's apparent to the people that they're living with. And it's difficult to move forward with the treatment until you find a way to answer that discrepancy. People that come into treatment are frequently confused, and it generally takes a couple of weeks for the confusion and the anger and the frustration about the intervention and about what's happened, for those things to settle, for the client to be able to have a much more accurate assessment of what's been going on in their lives. Once that has happened, we can get a much more clear picture of what's happened. That's frequently where we start to talk about the psychological assessment. that we get an assessment of what's happening in their lives, and also if there's any other diagnoses. That's those anxiety, depressive, trauma diagnoses that people are experiencing are the source of all of the discomfort in their life. And we really want to talk about how that discomfort that they're experiencing was the precursor for them to begin to use the substances or the behaviors that have become so problematic in their lives. If we don't treat those mental health diagnoses concurrently, we're never going to be able to impact the symptoms that they're having. So if we work through this in a logical order, the medical part of the evaluation really takes a look at what all of the other complicating medical factors are. We want to make sure that there aren't any medical issues that are causing the confusion, causing the difficulties that they're having. Chronic pain is a real consistent factor in addiction. And if people are so focused on their chronic pain, it's virtually impossible for you to redirect them to deal with what it is that's happening in their lives. If the medication is causing confusion, we want to, and that's a frequent issue. Also, we get people that are on so many medications that it's virtually impossible to tell what's appropriate and what's not. We want to get that straightened out. There's a spirituality assessment with all of the clergy and religious that we deal with. Their addictive behaviors, their mental health disorders have absolutely impacted their spiritual life. It's impacted their prayer life. We want to start to understand what's happening with that. We want to get those questions out and on the table and be able to have people start to talk about what's happening. Have them work with the chaplain, have them restart the spirituality that they're going to need, have them restart the community prayer, and really look at the disruption in their spiritual life as one of the consequences of their addictive behavior, that as they focused so heavily on their addiction that they've lost the thread of their spiritual life. Understanding those other mental health concerns is crucial. We need to make the diagnoses. And this afternoon, I'll be talking much more in depth about what those diagnoses are and how each of the individual diagnoses impact treatment. But it's important to understand that if you don't treat the mental health disorders concurrently with the addiction, people are not going to be able to A, recover, or B, have any kind of quality of life. We use a number of screening tools to help us understand what those diagnoses are. And we take a history. We want to understand what kind of therapy they've done previously. We want to understand what kind of medications have been tried previously. And we don't want to repeat previous mistakes, but we do want to use the history that people have to help us inform what it is we think will work. So along with their regular addiction treatment, they're going to be receiving mental health treatment. They're going to do individual therapy. They're going to do group therapy. It's really possible that they're going to be taking medications if the mental health diagnoses are significant enough. We have biofeedback training. And the neuropsychological testing that's listed on the slide has a lot to do with understanding where people are cognitively. It is not uncommon that people that have been involved with a lot of substance use have some cognitive impairment when they arrive. And some of the mental health diagnoses also have cognitive impairment that go along with them. We want to make sure that that gets stabilized and that people return to some level of working memory. The therapeutic things that impact that the most are that they get out of the anxiety-filled situation that they were in, that they start to get some exercise, that they start to eat nutritious food, and that they get sleep. Sleep is one of the most healing things that happens in a treatment center, and it's not till people start getting restorative sleep that their cognitive functioning improves. Until that level of cognitive functioning returns to something like normal, they are not going to benefit from insight-based treatment because they're just not going to remember the things that they've been told. And they're going to be focused so much on how uncomfortable that they are that they're not going to be able to focus on the healing process. And this is all parts of how the therapeutic process is engaged. All of those factors come together to inform how the addiction treatment happens. And with the addiction treatment, they're going to do many of the same things that they do with the mental health treatment. There's going to be individual therapy. There's going to be group therapy. There's going to be educational things. They're going to be reading about their diagnoses. They're going to be learning stress reduction, stress management techniques. They're going to be learning anger management techniques. And they're going to start to get engaged in community-based self-help groups, 12-step groups, AA, Gamblers Anonymous, adult children of dysfunctional families groups, that we're going to start to point out to them the resources that are available for them when they return home. Those are so crucial because people are not going to stay in treatment for a lifetime. The goal really is to help return them to the communities and the congregations that they came from. And if they're able to have community resources when they return, when they're able to find help where they live, it enhances all of the other efforts that were made in treatment. And so we're trying to teach new skills. We're trying to teach people how to engage in all of these self-help behaviors post-treatment. One of the most debilitating aspects of all addictive behaviors is that they are so isolating. That as people become more and more addicted, as they become more and more involved in their mental health symptoms, they withdraw from their communities. They withdraw from their friends. They withdraw from the support groups that they have. And they're ashamed of their behavior. They don't want to talk about the things that they've done. They don't want to let anybody know how uncomfortable they are, so they withdraw. The treatment process, all of this individual and group therapy, all the other techniques that we use are designed to help people get re-engaged in the process of interacting with other people, that they build that circle of trust, that they find people that they're willing to confide in, that they find people that they're willing to take their troubles to, that they start to see and understand that when they share their burdens, they feel better, and they need to get back into the habit of doing that. And 12-step groups and community-based support groups are excellent ways to make sure that those kinds of resources are available to them when they return home. There are benchmarks in treatment that we use. We talk about that they have to get past that sort of cognitive dissonance that they have in the beginning where there's that discrepancy between how they see the world and how the people around them see it, that they come to some level of acceptance of their diagnosis, that they see the harm that they've caused and they become willing to take a look at it. Another benchmark is the ability to recognize that they can get better, and that all of these, the medications and the therapy can be helpful, and that it's a commitment to continue to do that, that engaging with other people is helpful. And those are the hallmarks that we're looking for as people move through this process. We want them to understand through all of these techniques and through all of these tools that we give them that improvement is possible. At some point in the treatment, after they've accepted enough of these milestones, approximately 2/3 of the way through treatment, we want them to do a therapeutic leave. We want them to take a break from the treatment that they're doing with us and start to set up the resources that they're going to need to return home. That means that they have to find the 12-step groups that they're going to go to, that they find temporary sponsors, that they identify the people in their home living situation who can be a support group for them. These are the people that they're going to confide in. These are the people that they're going to turn to when they need help. That they find a therapist in their community. That they have that they start to look for a spiritual director or a spiritual companion. And that they have a meeting with the leadership of their community to talk about how things have gone, about the issues that led to the intervention in the first place, about the insights that the client has gotten over the course of time, and about how all of those difficulties are going to be addressed in the future. An inability to do that, an inability to have that kind of informed conversation with leadership means that they have not gained enough acceptance to be able to talk about going back and discharging from treatment. If those core issues have not been addressed, then they're only going to go back to their communities angry and not accepting of their diagnosis. And the entire efforts of the treatment team are about how do we get people to where they can go back and be with their communities and have positive interactions with them. After the therapeutic leave, we want to use all those things that were discussed during the therapeutic leave, the support groups, the therapists, the meetings, all those things have to go into a formalized continuing care plan. So that when somebody's ready to discharge, the things that they have to do when they go home are very clearly laid out, and that everybody has a shared understanding of what those things are, so that there's never any doubt about what people are supposed to do. That they, and that it's a written document, it's a written agreement between the client, guest house, and the community that they're returning to. And that these are the things that I'm going to do to stay healthy. Yesterday, when I was giving one of my presentations, I talked about what happened if I had a heart attack. And how important after the surgery was over and after I'd returned home, whether or not I followed the continuing care plan, the wellness plan that I had, is what was going to determine how well I was going to be doing, how healthy I was going to be. And that's the same with every chronic issue that people have, whether that's diabetes or heart disease or arthritis or whatever it is. That health and wellness plan is the thing that determines how healthy I'm going to be. So this plan is the capstone of the treatment program, that we need to have an agreement with everybody involved that these are the things that somebody's going to do. Because if somebody leaves treatment and does not put into effect all the things that they designed during treatment to help stay healthy, if they say, well, you know, I really don't have to go to those meetings anymore, or I shouldn't have to take medications. I don't think I want to do therapy anymore. The decision to do that is a decision to return to being unhealthy. That it's a return to not doing well. It's a refusal to engage in a plan for health and wellness. And we need to talk about that, because we know from years of experience that people that develop good health and wellness plans and then enact them do very well. Their treatment experience is positive, and they go back to their congregations, their communities to have healthy lives. The ones that refuse to do the follow-up care, the ones that refuse to use the new tools, are the ones that don't actually function very well. And we need to follow up and make sure that that those things are enacted. One of the pieces that I'll return to for the intervention is that we talked about, what are the consequences if somebody doesn't comply? What's going to happen to somebody if they don't go to treatment? Well, I would say that the refusal to follow up with the continuing care plan should bring into effect exactly the same consequences as refusing to go to treatment. That the community should already have decided what it wants to do, and you have to be prepared to put that in place. And if you're not prepared to do that, you're really sabotaging somebody's plan to stay healthy, because that's really what all this is about, is how somebody's going to stay healthy. We have to remember that relapse is a possibility. We have to remember that somebody can always return to this behavior. So the question is, what happens if somebody relapses? And when we developed that continuing care plan, when we said this is what's going to happen if when you go home, these are the things that you should do. The consequences of a relapse should be really well laid out in that document. If I return to alcohol use, if I start gambling again, if I refuse to follow my food plan as a compulsive overeater, here's what's going to happen. It might be a return to treatment. It might be finding outpatient services close to where you live. But there has to be a plan in place for what's going to happen, and that needs to be in place before somebody's discharged from treatment. It's crucial that that's part of the treatment plan. I apologize for the technological difficulties. My presentation likely would have flown just a little bit better if I had a better handle on this, but one of my grandchildren wasn't here to run it for me, so I'm kind of I stumble occasionally. So I'm going to invite you to return on your video, and I'm going to start answering the questions that have come up on the screen. The first one that I have is the goal of an intervention always that you want them to go into a treatment facility? I would say that if you have met as an intervention team and that you have decided that there's some problem that you don't understand and you don't know what it is, that the outcome of the intervention is that you want them to have an assessment, that you want their situation to be assessed by somebody with an expertise in the difficulty that you're experiencing. That you're telling the person that you're confused, that you don't understand what's happening, and that you want somebody that has more expertise in this area to give you an assessment. Sometimes that's done on an outpatient basis, sometimes not, but always the outcome of an intervention. If you think there was enough of a problem in the community, that you want that voice of an expert to chime in to help describe what it is that's going on. The next question that I have is, how common is it that the symptoms of a process addiction mimic those symptoms of an alcohol or drug addiction? Frequently, very frequently. And I have to tell you that sometimes it's medical issues. Sometimes people are confused, have memory problems, are stumbling, falling asleep because their medications are wrong, or they're mixing medications that shouldn't be put together. Sometimes it's that there's cognitive impairment from the beginning of a dementia process. Sometimes it's that they're hiding financial or personal issues that have nothing to do with addiction. And sometimes it's a process addiction that looks like a chemical addiction. That's one of the reasons that our assessment is 2 weeks long, is that we want to rule all of these factors out and come to an understanding of what it is that's going on. And it's frequently complicated. It requires the input of a number of people, medical, psychological, spiritual, and addiction focused, to really have a much better understanding of what's going on. The next question that I have is, what might some of the factors for a guest house not accepting a sister for treatment? So we'll go with I'll give you a list of the top 5. The first one is that they're suicidal or homicidal. If they have serious thoughts of hurting themselves or of hurting others, they're going to need to be in a psychiatric hospital until that's stabilized. We need to know that all of the people that are here are safe. If we get a referral for somebody who is accused of being a sexual predator, that they have been engaged in predatory behavior with other people, with minors or vulnerable adults, we do not accept or treat that scenario in this setting, and it makes the setting unsafe for the rest of the people that are here. Part of the assessment process is to look at people's cognitive impairment. If somebody is already so involved in a dementia or Alzheimer's process that they're just not cognitively able to benefit from treatment, that would be a rule out. We wouldn't be able to accept them. If people are so physically impaired that they're not able to do their own self-care, they can't take care of their daily toiletry and personal hygiene issues. Sometimes initially when people come in, they're so impaired by their addiction that we have to help them for a little while. But if on an ongoing basis they're not able to do that stuff independently, then they need to be in a different level of care than what it is that we provide. The last reason why someone wouldn't stay at guest house is because they refused. If this is all admissions to guest house are voluntary. Somebody has to be willing to sign themselves into the treatment center. If they absolutely positively refuse, we cannot hold them against their will. And guest house is not the administrator of consequences. The most frequent scenario is somebody's unwilling to stay for treatment. They go home and the community or their congregation says, well, that's fine, but here's what happens. You don't have a car to use anymore. You don't have we're not going to pay your credit card bill anymore. You're going to lose your job. That the community helps them understand that they're going to need to become willing to be in treatment in order for them to return to the community. But those consequences are administered by the congregation or the community, not by guest house. Those are the top reasons why somebody would not stay for treatment at guest house. Next question is, what is the average stay at guest house and what is the cost? Average length of stay for a woman religious at guest house is about 140 days. It's a little bit difficult to say for sure. Length of stay is frequently determined by the diagnoses that you have. Multiple diagnoses means that you're likely to be here, you're likely to be in treatment for a longer period of time. Average cost a guest house, the bill for our services is approximately $14,000 a month. Depends a little bit on how many services you use. The caveat to that is that we are a private nonprofit. We do a lot of fundraising. We have scholarships. We underwrite the cost of care, and we do not refuse treatment to anybody based on ability to pay. If you are a clergy or religious who needs our services, and the organization that you're with is not able to pay, Guest House will find a way to get that treatment paid for. We don't ever want money to be the reason why somebody doesn't get help. The next question that I have is that, can you say something about dementia caused by alcoholism? Alcohol is a very caustic substance. It, over the course of time, causes damage to all the soft tissue in the body, especially the brain and the liver. Just as a side note, if you have any doubts about that, and you're bored today, crack an egg into a glass of vodka and watch what happens. That egg will be fully cooked in about 90 seconds from the exposure to the alcohol. And that's exactly what it does to the soft tissue in your body. So alcohol destroys brain tissue. Some of the other aspects of consistent alcohol use also cause I'm going to say cognitive impairment before I talk about dementia. Long-term exposure to alcohol is just going to cause some cognitive impairment. Side note, the benzodiazepines, Valium, Xanax, also cause a lot of cognitive impairment and memory loss. They just do. If you've been exposed to alcohol or the benzodiazepines long enough, you are going to have some cognitive impairment. Part of the treatment process is to see how much of that has been sustained and whether or not abstinence, good exercise, sleep, and nutrition is going to restore some level of functioning. For long-term alcoholics, it can take up to 90 days before we find out whether your cognitive impairment is going to come back. There is a line that you cross with the dementia related to alcoholism. It's called Korsakoff's. If you enter into that, you've gone past the point of no return. You won't come back. But we're not generally able to make that determination until we're about 90 days into treatment. Next question I have is, what percentage of priests, sisters choose to abandon their vocation rather than accept treatment? That number is very, very, very small. Very small. I would put it down in the lower single digits. One of the pieces that I didn't cover with intervention that I should have is that we need to look at this as a process. Just because they didn't accept your first invitation to go to treatment at the end of the intervention doesn't mean that you don't want to go back to them a couple of days later and a week later and a month later and be really consistent in inviting them, because a lot of people that say, well, I will leave before I do that. If you give them a large enough space and a little bit of time and some consequences, you can help them change their minds. But the number of people who actually just completely walk away is very small. Does medical marijuana have a place in recovery programs? Absolutely, positively, unequivocally, no. Marijuana is a mood-altering substance. I know that society and politics has turned away from that. Everything that marijuana can be used to quote unquote treat can be treated in another fashion. It just can. It is a mood altering substance. It changes how people perceive things. It changes their mood, their affect, and it is not a workable part of an ongoing healthy recovery plan, in my estimation, or our medical director's estimation, and for most of the people that are involved in a 12-step recovery program, this would be a not an ongoing acceptable recommendation. All right, we have reached time for a 45-minute break. I hope some of you can have some lunch. Please feel free to send me a message or give me a call if there's a question that you'd like to answer that I couldn't get to in this period of time. I apologize again for the technical difficulties, and thank you for your time this morning.
Okay, everybody, we're going to start back up at 1:15 Eastern time. That's 1:15 Eastern time in 45 minutes. Jeff, welcome back, everybody.
Thank you. Before I start on talking about the mental health, I'm just one of the last question that came in after the last presentation is anger an addiction, and how can it be tested? And anger, in fact, does not meet the criteria for being an addiction. It is one of the symptoms of addiction, and it's one of the symptoms of many other mental health concerns. That anger pops up, but it's in and of itself, it's not freestanding as an addiction diagnosis. We do treat it at Guest House as one of the symptoms of addiction and mental health problems. How can it be tested? Boy, the people around you are pretty willing to tell you when you look angry. It's not hard to determine. Frequently, the people that are experiencing the anger don't recognize it, but in and of itself, it's not hard to. It has some biological components: the racing pulse, the flushed face. It comes out in the behavior, so it's not hard to diagnose. Usually what's necessary is to treat the discomfort that's underneath it, whether it's the compulsive behavior, the addiction, or the emotional struggles that people are having. You need to treat those in order to get the anger under control. There are really good anger management techniques out there. There's a lot of work that can be done. It is a very treatable symptom. All right. let's try this technology one more time. See how.
If I could just ask everybody again to stop your video and mute yourselves.
So approximately 70% of people that are diagnosed with an addictive disorder, that's at guest house or in lay treatment centers, but about 70% of them are going to have what's called a comorbid diagnosis, that they're going to have a mental health concern that goes along with it. It's in lay population, but it's also very true at guest house. The vast majority of people that we treat here have more than one diagnosis. This presentation was originally developed by Dr. Roberto Bermudez. He's our clinical director, and he is not available to give the presentation, so you get me today. We need to think about psychological disorders as signs of distress and impaired functioning. They range from really mild symptoms to quite severe. At guest house, we're much more likely to be treating the fairly mild disorders. We don't generally treat schizophrenia or the diagnoses that have extreme mood swings that can potentially cause violent and disruptive behavior. How do you go about determining what's abnormal behavior? That's really, really a difficult question. It exists on a continuum, and a lot of work goes into trying to figure it out. We talk about distress, we talk about maladaptive behaviors, we talk about deviant behaviors. We talk about people who are operating out of the standards of what normal communities, normal society would describe as acceptable behavior. With the anxiety disorders, the trauma, it's usually about social discomfort. It's about irrationality, unpredictable behavior. And at the far extreme, we talk about dangerousness. But we're looking for behavior that, for lack of a better way of saying it, it's not socially acceptable. The indicators are when people are not following cultural norms, what is considered to be generally accepted behavior in the setting that you're in, and people are not able to comply with that. We classify psychological disorders. There's a book called the Diagnostic and Statistical Manual. Shorthand for that is the DSM-5, and it's essentially a cookbook with a list of each disorder and all of the symptoms that go along with that particular disorder. It utilizes a multi-axial system. So, and the axes are really talking about how people's behavior is impaired by the diagnosis. Really important to recognize that there is no blood test for a mental health disorder. There is no give a person a test and we automatically know. We have to watch people's behavior. We have to get reports of the behavior. We have to talk about how it impairs their functioning. And that's how we make the diagnosis. So in some ways, it's very different than a biological or a medical diagnosis. So we're looking for those clinically significant disturbances in behavior, emotions, cognitive function. It's generally associated with some level of distress or disability. And long-term, it can be either attributed to or cause some biological and psychological dysfunction in the individual. People, for instance, that have depression frequently have a disruption of their neurotransmitters. They might have a disruption of some of the neurotransmitters in their brain. But it's fluid, and it exists across multi aspects of people's lives. Why do we go to all this trouble to classify? It's so that we can have a common language. It's so that when we're talking about a diagnosis, when we're talking about what somebody's experiencing, we have a really clear way of saying, yes, we know this is depression because this, and this is present. We know that this meets criteria to be trauma because of the things that exist. When you have clear criteria like that, it's easier to track a diagnosis. It's easier to do research on the diagnosis. And it's easier to talk about knowing what works to treat that diagnosis and what doesn't what doesn't work to treat that diagnosis. A lot of times in our common interactions and our language, we diagnose the people around us all the time. Turns out there was a president really recently who keeps getting diagnosed with narcissistic personality disorder. Unfortunately, he doesn't meet most of the criteria for the actual diagnosis, but it meets the criteria that most of us think about when we talk about a narcissist. And so when somebody comes to us and anecdotally we hear that they have trauma or they have anxiety, we want to hold that up against some really clear criteria so that we know that that's actually what we're dealing with. One of the reasons that we talk about not making those kinds of diagnoses is because there's still a lot of stigma in the world around us about people with mental health diagnoses. There's people hear it, that they have a diagnosis, and they think that they're damaged goods, that people make judgments about us if they hear our diagnoses. It's one of the reasons why all of the information at Guest House is protected information, that it's protected by HIPAA, that we don't disclose this information to anybody that doesn't have a release for it and doesn't need to know it. And we go to great lengths to help people get to some level of acceptance, that the diagnosis isn't a label to be used to be stigmatizing them, but it is a framework that we can use to talk about how to help them. We talk about mental health diagnoses as being disorders. Anxiety disorders, mood disorders, personality disorders, all exist on a continuum. We see all of these diagnoses here in the treatment center. Anxiety disorders are absolutely the most prevalent. Anxiety is that overwhelming feeling of something's going to go wrong, that I'm focused on the future, and I spend a lot of time worrying about something bad is going to happen. It's cognitive, and it has some real biological components to it. So we want to talk about anxiety disorders as being about unrealistic and irrational fears, that they cause significant distress, and the distress that's caused by them is significant enough that it impairs our ability to function. DSM-5 talks about 5 primary types. There's phobias, fear of specific things happening, social anxiety, that's a real apprehension about socializing with other people. Panic disorder, almost always thought of as panic attacks. One of the most surprising things that happened to me when I started working with the men at the men's treatment center 20 years ago was the number of men who came to treatment who had panic attacks when thinking about giving a homily. I was floored that people had something so core to their daily functioning that literally caused them panic attacks. It almost always resulted in either alcohol or benzodiazepine use, and their addiction started around that panic attack. Agoraphobia is that fear of being in public, and generalized anxiety disorder, probably the most common one that we treat here is just that fear of unreasonable things happening in our life every day for a significant amount of time that it impairs our ability to function. The symptoms are all, they're listed here. I'm not going to go through each of them individually, but I want you to just understand that in order to get the diagnosis, the symptoms have to be so significant that they're impairing your daily ability to function. And that means your sleep and your ability to do what you're trying to do. 3% of the population have a generalized anxiety disorder at any given time. Lifetime prevalence, 5.7% of the population is going to have this. It's twice as likely in women as it is in men. And 60 to 80% of the people reporting it describe having it from a very early period of their time, and it is a lifelong aspect of who they are. The generalized anxiety disorder, it goes along well with other anxiety disorders, and it's also really a precursor for some people to have those occasional panic attacks. There's a lot of psychological and environmental causes. This aspect of the diagnosis is a doctoral level, multiple doctoral level courses and work just to try and understand. But it's the concept that it really comes from multiple sources and impacts multiple parts of our lives. It is genetic in most cases. It does affect the neurotransmitters in our brains, and it also affects the stress hormones that we have in our body. There's some scientific work that indicates that one of the reasons that women have an increased incidence of the generalized anxiety disorder is that this stress hormone is also significantly interacts with estrogen, and the work around that is also fairly significant. Treatment at guest house. It's group therapy. It starts with a diagnosis. There's absolutely no way to address this without making sure that you've made an accurate diagnosis of what you're doing. Then we use all the different kinds of therapies and education. The psychiatrist gets involved because in order to impact anxiety, frequently you need to utilize medications. It's difficult. It requires an addiction psychiatrist and an addiction-informed psychiatrist, because the vast majority of medications that are used by psychiatrists to treat anxiety are highly addictive. That's Valium, Xanax, Ativan. Everything in that family is very addictive. Frequently, people with anxiety disorders end up in treatment because of their addiction. So treating them with yet another addictive substance is not something that's going to work very well. There are non-addictive substances that can be used, but it's a much more difficult process, and it requires an addiction-informed psychiatrist to do that. The psychologist always gets involved. There are very specific therapies that are used for the different diagnoses. There are exposure therapies that are used for people with phobias to help get them desensitized to the things that they're phobic about. There are rehearsal practices that people can go through. There are coping skills that you can use so that when you recognize a panic attack happening, you have the ability to work your way out of it. Cognitive behavioral therapy works pretty well with generalized anxiety disorder, but it requires somebody with a good understanding. Medical and nursing are always involved because anxiety disorders, panic attacks have multiple impacts on the human body and a lot of medical symptoms that go along with it. We want to make sure that those are treated. Physical therapy is involved because exercise, relaxation techniques, stretching, Tai Chi, lots of other non-medication medical approaches can teach people how to relax and teach people in a non-medicinal way how to cope with some of this. Nutrition. The correlation between good mental health and good nutrition is really significant. In order for our bodies to perform at a peak and optimal way for our bodies to be able to manufacture the neurotransmitters, to have good responses, frequently means eliminating too much sugar, eliminating caffeine and other things that we take into our bodies that actually heighten our anxiety. So nutrition plays a really incredibly important role in this. Spirituality is also incorporated. Much of the distress that people have around anxiety is either related to their ministry or to other stress factors that they have in their lives. And getting involved with with our spiritual director is one of the key tools that we use to help people get additional coping skills. The next most significant diagnosis that we treat at Guest House concurrent to the addiction is mood disorders. That translates extremes of emotions, being unable to keep a balanced affect, that you're either way low, depressed, or manic, hyper, going to the other extreme. The two key moods around that, we're talking about depression and mania. We treat straightforward depression way more frequently than we treat mania. And the combination of the two is the bipolar disorder, where you get both. We don't treat a lot of mania at Guest House, but we do see a substantial amount of depression. It's interesting to note that alcohol is a central nervous system depressant, and that long-term exposure to alcohol results in depressive symptoms. Amazingly, people report drinking because they felt depressed in the first place. And that alcohol has this disinhibiting effect. It helps us to not focus on our problems for a short period of time. It helps us to feel better for brief periods of time. Unfortunately, long-term exposure to it will make you depressed, even if you didn't start drinking because you were depressed in the first place. So for those people who are already depressed, who drink for a significant period of time, are very likely to have a major depressive disorder or by the time they arrive at a treatment center. The symptoms, I'm not going to read all of them to you, but it has to do with hopelessness. It has to do with suicidal thoughts, sadness, trouble concentrating. It permeates every single aspect of our lives. It takes the joy out of our lives. It makes it difficult for us to think about doing things and moving forward with the things that we know we should be doing today. Lifetime prevalence, 17% of the population. So it has a much higher level of prevalence throughout the society than the anxiety disorder do. In a 12-month period, 7% of the population is going to be suffering from depression. I would guess that if I was smart enough and had enough money to do a research project, that number has increased during the COVID pandemic as we're stressed out with everything else. It's about twice as common in women as it is in men. The lifetime prevalence for the bipolar disorder, that's the part where the mania and the depression are present together, is in about 1% of the population. Important because the bipolar disorder with the two extremes is a much more debilitating diagnosis than straightforward depression is. The people that have the bipolar disorder are going to have a lot more disruption in their lives. So the major depressive disorder, that's the one that you're most likely to see in the long-term chronic alcohol users. That means that you have the major depression and you don't have any of the mania. If you have the mania, it's a separate diagnosis. If you have major depressive disorders, it's really likely that it's going to be a reoccurring thing in your life. The vast majority of people that have these have more than one of them in their lives. It's frequently attached to the level of stress that you have in your life. There are lots of biological causes. Some people inherit the predisposition for having this. Other chronic illnesses and sleep difficulties greatly increase the chances that you're going to have a major depressive disorder, and that significant amounts of chemical use are often precursors to a major depressive disorder. So stressful events in life cause them, and then the risk factors that you have, that's the personal genetics that you have, and what we call the early adversity in life. One of the things that we know from about addiction is that people that experience trauma earlier in their lives are much more likely to have problems with mental health issues and addiction later in life. There's a screening tool called ACEs, and ACES, and it has to do with early childhood adversity and how much adversity you have in your early childhood. Those early childhood experiences really predispose us to have problems with lots of other issues in our lives. They're often present with the diagnoses that I won't be talking about today, and that's the adult children of dysfunctional families. They usually have very high ACEs scores. They have a lot of trauma and dysfunction early in their lives. The treatment at guest house is incredibly similar to what it is that we use with the anxiety disorders. For most depression, medications are strongly indicated. And that getting really specific psychological adjunct therapy tailored to the experiences that people are having is crucial to having an impact on their symptoms. Requires psychiatrists and psychologists that have a really good understanding of addiction as well as the mental health diagnoses. We want to make sure that they don't use medications that aren't indicated for addicted people, and we don't want to confuse the symptoms of the addiction with the symptoms of the mental health diagnosis. And really frequently, those are hard to discern up front. Just because somebody's depressed, for instance, when they come into guest house, does not mean that after 30 or 45 days of abstinence that those symptoms aren't going to go away. After all the stress is gone, they start sleeping again, they have all the chemicals out of their system, they're starting to get some exercise, they're sleeping well, the depression might very well go away. And so we wouldn't want to start them on a round of powerful medications that they don't need to be on if it's going to take care of itself naturally just from feeling healthy. So part of this process is just an ongoing assessment. We do an ongoing, we do an assessment on day one of treatment of all of these symptoms, and they're performed bi-weekly after that. We're just taking a look at the symptoms and seeing where they are today, not necessarily where they were when they presented. And the goal is to have people on as few medications as possible, and to be able to determine whether the therapy that they're getting, whether that's group, individual, or educational, is meeting the needs of their diagnosis. And we want to stand prepared to be able to alter the course of treatment if what we're doing is not having an impact on their symptoms. And that really requires a very regular assessment. One of the most difficult part about major depression and people being on medications is that they get on a medication. We determine that it's not part of the alcohol withdrawal, that it's not going to clear up with talk therapy and good sleep, and they need to be on medications. One of the most heartbreaking parts about it is that sometimes after 6 months or a year, the medication that was working stops working. And we need to be prepared to have the safety net in place so that the medications stop working. We're prepared to get them in to see a professional and start the search for a new medication that will work. Another really important part about this, and it doesn't usually happen in treatment, it happens after treatment, and it happens very frequently with people with depression and bipolar disorder, is that they start to feel so good that they stop taking their medications. So that ongoing continuing care plan, that ongoing ability to watch how people are doing, when you see the decline in their functioning, when you see the return of the symptoms, you want to automatically look at whether or not they're taking their medications and whether or not they're taking them as prescribed. And frequently, relapse into the addiction starts with a flare-up of the mental health symptoms not being treated well. So this is a chronic disorder. It's lifelong, and all of our efforts have to talk about how to keep people healthy with this over the course of time. So part of the education that we give is part of the treatment is to make sure that people understand that this is a lifelong diagnosis, and we want to be sure to make that they continue to address it concurrently with the addiction. The third most likely diagnosis that we're going to see in guest house is the adjustment disorder. The symptoms for this are a little bit more tenuous than the anxiety and the depression. It's not always as clear what it is going on. But the way to talk about it is that their response to stress, their response to things that they don't have good coping skills for, that their response is out of proportion with the stress that they're under, that they just don't appear to be handling their stress very well. It's the reason it's called adjustment disorder. Frequently it happens when people are experiencing change or disruption in the normal patterns of their lives, and they really just don't adjust very well. They talk about being sad and hopeless, but not to the extent that it would meet the criteria for depression, that they're nervous, they're anxious, that they have some mix of depression and anxiety. They never rise to the level of being as debilitating as a full-blown anxiety disorder or a full-blown depressive disorder, but it does cause them to be confused, and it does cause them to actually not function very well. Many of the people that we admit to guest house meet the criteria for this diagnosis on admission. Their lives are out of control, and they don't know how to handle the stress that they're under. This is compounded by the fact that being an active alcoholic or involved in some compulsive behavior is anxiety provoking. It's taking more of their time. It's taking more of their money. They have behavior that they're trying to hide from other people. They're afraid they're going to get caught. They're afraid somebody's going to smell the alcohol, or somebody's going to report the money missing. They live in dread, and so they meet all the criteria for this adjustment disorder because they're really just not coping with the stress very well. Frequently, it's, as I said, it's the reaction to an event. They have the stressors, and there isn't, for the most part, there isn't one single thing that causes it. But long term, there's a slow building, sort of like a pressure cooker coming up to steam. That as the pressure increases, as the dysfunction increases, the disorder starts to manifest. You'll see them crying, they argue, they ignore their responsibilities. They start to avoid friends and family. It's just really clear that they're experiencing a fair amount of dysfunction and inability to handle the stress in their lives. They have physical symptoms, trouble eating, difficulty sleeping, difficulty concentrating. You'll see it in their mood and their affect, and you'll see it in their interactions with other people, particularly with the people that they're closest to. Use all of the same modalities and treatment to really address this. It's not a disorder. A, it's not as debilitating as the other major diagnoses, and B, it doesn't really actually respond to medications nearly as well as depression or anxiety do. It is the one that's much more likely to clear up as soon as you've been able to A, remove the stressors from people's lives, and then B, help teach them new coping skills for dealing with their stress and their anxiety, and then helping them recognize the connection between their addictive behaviors and the stress. And so that when they make the realization that a lot of my stress was caused by my addictive behavior, and that if I don't engage in the addictive behavior, then I'm going to lower my stress level. That insight is very useful in the treatment process. Probably the most damaging diagnosis that we get, the one that's the most insidious, is trauma and PTSD. It's that emotional response to a terrible event. Important to note that what might be very traumatic for me might not be traumatic for other people. That it has an impact on a wide variety of emotions. Some people get very angry. Some people go into shock and completely shut down. Of all the diagnoses, it's the one that's most significantly correlated with chemical use, that people are so uncomfortable with the way they feel that they frequently turn to chemicals like alcohol and other drugs. It has a disastrous long-term effect on people's well-being because of the chemical use, because it destroys relationships, because it makes it very difficult for people to have close relationships, to seek help. So there is the difference between trauma and the full-blown diagnosis of post-traumatic stress disorder. The PTSD being the most significant of them. It's the one that you think about from survivors of military actions where they saw combat, or people that were involved in horrific accidents, or concentration camps, or just being witness to really horrific things. There's lots of other things that can trigger it that are not as sort of global as a concentration camp or war, and that's physical abuse, sexual abuse, domestic violence, emotional abuse, neglect, the loss of a loved one. It can happen as a single event. It can be cumulative from ongoing recurring events. There's such a thing as the complex trauma. That's one traumatic event built on top of another traumatic event, on top of another traumatic event. That's also tied to intergenerational trauma. So families that have grown up with a lot of intergenerational violence and poverty and histories of abuse in the family create a scenario where this really complex trauma is there. It's woven into the fiber of people's beings. So people that have, I talked briefly before about the ACEs, that assessment of those early childhood trauma. A young man with a strong high ACEs that experienced a lot of trauma as a child and as an adolescent, that goes into a theater of war and experiences really traumatic events during the war, is so much more likely to have the complex trauma than somebody that grew up in an intact home that didn't have the early high incidents of trauma. It exists across, it's acute, it's chronic, it can be complex. We frequently see the secondary trauma, the vicarious trauma. That's based on the vocations and the ministries that almost everybody on this call has. We are there to work with other people and hear about their problems and hear their horror stories. And long-term exposure to that causes what's called vicarious trauma. It becomes traumatic to me after I've heard all of the trauma from other people. And that's whether you're a mental health professional, a family member, clergy, and religious. And we can have some of the most debilitating symptoms as well, just because of our exposure to it. The symptoms are global. They're across all aspects of our lives. It can be shock, it's numbness, it's hopelessness, and it mimics a lot of the symptoms of depression in that way. So part of the differentiation process is making sure that the symptoms that we're seeing are tied to trauma and not tied to tied to a depressive disorder. Physical symptoms are insomnia, nightmares, fatigue, racing heartbeats. There again, you'll see some of this looks exactly like anxiety, and trauma and PTSD can actually look like anxiety. It's important to differentiate because the treatments for them are different. This is what's called a hypothetical hierarchy of trauma. Goes from low exposure to high exposure, and it puts in order what we would call the lower the things that are going to induce those low levels of trauma versus the ones that are high. Obviously, seeing violence and death and injury are potentially much more damaging to people than the lower levels. But this is all very contingent on what kind of resiliency people have and what level of trauma they've already experienced in their lives. It is, in fact, significantly related to brain development and how our brain develops has a lot to do with how these different symptoms of trauma and PTSD are going to affect our functioning, and how how it impacts our cognition, how it impacts our survival instinct. These are educational pieces that we try and use for people that are suffering from PTSD and trauma to help them understand why they've had such an impact on their lives. This slide talks about the responses that we have to trauma. They're not necessarily important immediately from a treatment perspective, but it does help people understand why they've had the response to trauma that they've had in their lives, that it's biological, that our body just generates these survival instincts, and that we do use these characteristics to help us decide what kind of therapy and what kind of treatment we might want to use to help people deal with this. This is a really involved slide. It talks about how it impacts different personality types. My presentation is already sort of running a little longer than I anticipated, so I'm not going to spend a lot of time. These are not important for making the diagnosis, but they are really important for trying to help people that are in treatment understand what the symptoms that they experienced were and why they felt the way that they felt. This slide is also directly related to that. And it talks about how they developed the coping skills that they did. This is specifically talking about the full-blown part of the trauma. And this is for people that get the full diagnosis of PTSD. That's the flashbacks, that's the nightmares, that's the severe anxiety, and that's that just complete uncontrollable thoughts about the event and the reliving over and over of the events that you experienced. Medications and talk therapy are a significant part of this. This requires a very involved and specific treatment. If you're going to walk people back through the experiences, the traumatic experiences that they have, you need therapists that are very well prepared to do that. This is not an entry-level counselor's job. This is a very sophisticated form of treatment. And that really impacts, how we treat this at Guest House. The medications are very specific. There's a whole specialty around how addiction and PTSD are interrelated. I ran a program in California for veterans returning from the Gulf War that had the diagnosis of PTSD and a chemical dependency. In that program for the veterans, it was most frequently narcotics. The specialty treatments that were necessary to return them to physical health with their addiction, and then treat those really complex war memories was a specialty that required a lot of in-depth training and some very specific protocols. It's a difficult the two together are a difficult diagnosis to treat. I'm going to put a plug in for another program. You'll see the link for Trauma Recovery Associates. The main principal person behind this is Father Ken Schmidt. He's out of the Diocese of Kalamazoo, Michigan. He has developed a program for dioceses and organizations to help do education around trauma. He has an online program that's free and available. I encourage you to have a look at it. Father Ken is my go-to consultant around trauma. Has a very informed program and has a really good understanding of a number of the factors inside of the church that have led to some of the trauma that we're experiencing today. EMDR is one of the techniques that we use to deal with trauma. I'm not going to go into what it's about, but it's a very specific, it's not necessarily something that we use with PTSD, but it is something that we use with the lower forms of the trauma. It's an interesting therapy, and we've seen a fair amount of efficacy from using it. Basically, the clients that engage in it report a lot of good outcomes and a relief of symptoms. Time for questions. All right. First question. It's about that we might see more cases of PTSD in our members due to the pandemic. What symptoms might we expect? Is Guest House considering doing a webinar? I want to make a distinction here. I'm talking about the fact that I think we're going to see more cases of trauma, not necessarily PTSD. That I think for many people, the isolation and the quarantining that has gone along with the pandemic, the people not not having their normal social connections, they're not having the ability to engage in the parts of their ministry that they found so life-giving, spending way more time in their room alone. It is going to be very traumatic for people. And for people that have already had some level of being disenfranchised, being lonely, not feeling useful, this is going to be traumatic for them. It really is. I think it's also going to be traumatic if you think about the number of congregations that have lost significant numbers of their members. The fact that we have had thousands of funerals and not been able to attend the funerals. Of having somebody that you care about deeply, that you've spent big pieces of your life with, whether that's another member or a family member or a friend that you're close to that was in the hospital and you weren't able to go and see them to say goodbye, that you know that they died alone with no comfort from the people that loved them and cared about them. These are all trauma-inducing experiences. And if you were abducted today and they wanted to brainwash you, the first thing that they would do is isolate you. They'd cut off all of your connections. They'd make you feel disenfranchised. And that isolation leads to an escalation of mental health symptoms. It does for everybody. So to think that that isn't going to happen as an outcome of this, of all the isolation that we've had, would be kind of surprising. So yes, I do expect it. And the symptoms that we'll be looking for, disruption of sleep patterns, engaging in lots of distracting behaviors. After the isolation is over, people still not wanting to leave their rooms, spending way too much time on the internet, mental confusion, the personality change, the either the aggressiveness or the completely withdrawn. And so it exists on a continuum there. So what we would want to talk about there is a change in personality. If the person that you encounter post-pandemic has a personality that's significantly different than the one that they went into the pandemic with, that would be a sign that they aren't doing very well. And yes, we absolutely will be getting together a webinar about this. It's on our radar. We're doing some consultations, just trying to figure out how to get this together. But we experience a significant upswing in the incidences of this, and in the addiction and in the addictive behaviors, and in the depression and in the anxiety, the compulsive overeating, all of it. We expect an increase in all of it. And so post-pandemic, we will be having some additional trainings about this. We're coming in. We have about 5 minutes left. Are there any other questions that I can answer for people? We covered a lot of ground today, and my expectation was not to have anybody become an expert on any one of these diagnoses, but it's understanding that there's a significant correlation between having the distress that's caused by the mental health diagnoses and then turning to alcohol, drugs, or some other compulsive behavior to relieve the distress that I have because of the mental health symptoms. Conversely, engaging in the very stressful addictive behaviors causes the mental health symptoms in some people as well. And it's difficult to know sometimes what came first, the chicken or the egg. And a lot of our assessment process is to try and figure that out, because how you do treatment is highly dependent on how the symptoms developed in the first place.
Jeff, just to comment here, so many of our members, as they're aging, this stress shows up. They covered it up for many years through their ministry and through the work they did. And when they get into retirement, the underlying trauma that's been a part of their lives for a long time is showing up. That's one of the reasons that when people come into treatment, many of them have to stay longer to deal with both the addiction and the underlying stress. And often the addiction has started later on in life. It's not a early stage addiction that has just progressed, but it has progressed very quickly. And so on less alcohol, they're having the very same problems as if they were very heavy drinkers for a long time. And the same thing with the eating disorders. So many of the women have they've lived for years bearing the childhood stress that's been a part of their lives. And so it's a really encouraging to encourage you to see the pain and allow them an opportunity and encouragement. And they feel hopeless. They feel their age is against them, and they feel that they should have done something better in order to avoid this. So when you see this among your older people, please help them get some help, and we can be helpful with that too. Thank you.
I have a new question, and it is, does guest house treat mental disorders without addictions present? And the answer is yes, we do. In religious women, the common denominator is there's almost always an adult child of dysfunctional family component to the disorder. But yes, we treat all of the mental health disorders freestanding at guest house.
Anybody else? Oh, here's one more.
Probably the last question that I can answer. How do we start these conversations with younger religious persons so that it doesn't take them having a crisis as they age for us to discover something? There's two parts about that, and that's the first one is when I talked about doing an intervention, I talked about doing everything that we do with love. But I also talked about making it really clear what our concerns are, making it really clear what our expectations are, and making it clear what our standards are. And I would strongly encourage you to have that be an ongoing part of your relationship with all of your members, that you talk to them when they're much younger, and that you don't wait for it to become a problem. When it's just irritating, when it's something that you don't understand, when you see something that's that's just not quite right and off-putting, that you'd be willing to have a non-threatening, non-accusatorial conversation about that. And one of the pieces that I can tell you is in the last 6 months, we've done 2 assessments and very brief treatments with younger members of religious communities that were struggling. It had not grown into a full-blown disorder, but they were not handling their stress well, and they were starting to engage in some behaviors that made it that were unacceptable to the people around them. We were able to do that assessment, give them some new coping skills, and talk about a way to refocus before something bad happens. That kind of education and early assessment is very effective, and it frequently it heads off more difficult conversations later.
Well, I think that concludes our time for this session. Jeff, thank you so much. That was an excellent presentation and great questions, everybody. We are now going to take a 15-minute break, and we will start back up at the bottom of the hour with our Director of Education, Father Mark Stelzer. So it's a good time to take a break, and we'll see you all back in 15 minutes. Well, welcome back, everybody, and thank you so much. We are in our last phase here of our 2-day Walking with the Wounded event, and we are so delighted that you've been able to spend these last 2 days with us. Our last speaker today is Father Mark Stelzer, who is a priest of the Diocese of Springfield, Massachusetts. Father Mark is our Director of Education, and along with Mary Jean and myself, Father Mark and I have toured many seminaries around the country, offering presentations and to religious communities as well on many of the topics that you've heard today. But it's also very important that our seminarians and people in formation hear much of this message. Not everybody that is in formation for ministry is going to battle addiction, but everybody in ministry comes across people who do suffer from addiction. And so the more we can provide information, education, and treatment and care, which are the core pillars of our mission statement at Guest House, we're able to help sustain the church in its role of ministering to God's people. So I'm going to let Father Mark offer a broader, wider introduction of himself. And then again, if you could, once we start sharing the screen and the presentation is up, if you could please stop your video and mute yourselves. So with that, I introduce you to Father Mark Stelzer.
Thank you so much, Chris. As Chris mentioned, my name is Mark Stelzer. I'm a priest of the Diocese of Springfield in Massachusetts. For those of you not familiar with that part of the world, we're about 100 miles west of Boston. And the first thing people always say to me is, you don't sound like you're from Boston. The Boston accent stops somewhere around Worcester, but I've been in Springfield all of my life. I'm stationed in Chicopee, Massachusetts right now, which is a suburb of Springfield, working mostly at our college. And I am also the administrator of not one, but 3 parishes in the city of Holyoke that are getting ready to merge. Largely ethnic parish combined of Irish immigrants, and 2 of the smaller parishes are largely Latino immigrants. So it's been a very interesting dynamic, and I consider myself blessed to be able to have the opportunity to work on that project until a new pastor can come in to take over the helm once the merger is done. You'll hear a lot of my stories as we go through the presentation, and in the interest of time, I'm just going to start sharing the slide deck. And just so you know ahead of time, for all you type A people like myself, this slide deck will be made available to you by Colleen, who assists us in the education outreach at Guest House. As soon as I am done presenting today, Colleen will get a PDF of this presentation to you. So please don't feel that you need to take copious notes. If anything interests you, you'll have all of this right as soon as we're finished today, sometime around 5 o'clock. And it certainly is an honor for me to be with you. That's a picture of the College of Our Lady of the Elms, where I've been on the faculty almost since the time I was ordained. The president of the college, whom many of you might know, the former president of the LCWR, Mary Dooley, asked me to come just part-time for 6 weeks to teach in the summer. And somehow that 6 weeks has turned into 34 years of either being here full-time or part-time, and serving at one point at 2 junctures as acting president of the college. So my life has been here with the Sisters of St. Joseph. When I came to campus many years ago, there were about 30 sisters still on campus. Presently, we have 3 Sisters of St. Joseph who keep that wonderful legacy alive. And my own background is that I am a graduate of Cathedral High School in Springfield, where I had the Sisters of St. Joseph, and prior to that was educated by the Sisters of Notre Dame at Sacred Heart in Springfield. So I'm very grateful for the impact that women religious have had on my own life and my own vocation. I always tell people that my first pastor was a Sister of Notre Dame, Thomasine O'Connor, who was my field placement supervisor my diaconate year. And from Thomasine, I learned so much about ministry, about life, and what it is to be a priest. And all that I have learned from those wonderful women religious has really benefited me in my current work at Guest House as Director of Education, when I have opportunities to meet firsthand with women in treatment, and then also to see our sister alums when they come back for continuing care activities on campus. I'm especially blessed at the Elms to work with the campus minister, who is also an alum of Guest House. So we have our own little thing going here, our own little Guest House world right here at the Elms. And that's a little, give you a sense of the parish where I'm working, inner city parish, again, built by Irish immigrants. And this will become the primary worship site for 2 other communities within a few months or so. When we begin talking about spirituality and addiction and talking about continuing care, I always like to set the discussion within the context of my own experience, the only experience which I can genuinely validate as my own, but which seems to be the general experience of so many people, so many men and women going through treatment at Guest House, and so many men and women who are also alums of Guest House. And the sentiment is this, that on the day we're ordained or professed, or the day we enter the seminary or religious community, none of us ever thinks that an addiction or mental health disorder is going to be part of our history. I certainly didn't think that on the day of my ordination back in 1983. And yet in 1999, 16 years later, I would land at Guest House as a person addicted to alcohol and begin the journey on their campus, which was then located in Rochester, the Men's Treatment Center. And we see so many other images of people in the scrapbook that you can look at on the day of profession, and a couple of images of the Guest House properties. And we never think that our lives are going to bring us to certain places. And I guess that's just part of the faith with which we enter into the journey of life itself, and certainly on the journey of religious life. I always tell people when speaking at AA meetings myself that my life didn't go as was planned. And in retrospect, I've come to see that that was okay. When I left the seminary back in 1983, the formation faculty was telling me that they wanted me back on the faculty, that after a few years of parish experience, they'd intervene with the bishop to have me sent away for an advanced degree, and they'd love to have me come back. I did very well academically. I did well in pastoral settings, and the faculty kept trying to say, you'd be a great influence, a great role model. We'd love to have you as one of us. But that never happened as a direct result of my alcoholism. My alcoholism took me to other places, to some very, very dark places. And when we talk about that journey in retrospect, a journey I began more than 20 years ago, I look back at the places where I thought I was going to go, or what was expected of me by myself and others, and where I am now. And with the grace of recovery and 12-step recovery, with the help of so much of what I've learned through Guest House, first as a client there and now working with Guest House and with all of our alums, that the place God brings us and the place where we are is the place where God exactly means us to be. And the fulfillment that I find in doing what I do as a parish priest, what I do as an educator, what I do on behalf of Guest House, that this becomes a fulfillment in my ministry. And it was addiction that brought me to this place. Again, the day of ordination of profession, we certainly don't have any expectations that treatment and intervention and continuing care and ongoing work of 12-step programs would be part of our lives. So here is the treatment center, an image of the treatment center in Rochester, where I began that journey, sort of sacred ground in my life. This facility where men only were treated was closed a few years ago, 6 years ago so, and moved back to Lake Orion, where men and women are treated in separate programs, but on one campus. And when I was discharged from treatment in 1999, after 3 months at Guest House in Rochester, I came back to the Elms, but the bishop also suggested that I might want to consider working at Bay State Medical Center just down the street as one of the on-call chaplains there. And it was there that I saw other people living with the same disease I have, the disease of addiction, alcoholism in particular. It's there as a chaplain that I began to work with people in the detox unit and in the 30-day stabilization unit. It was there that my interest was sparked in learning more about addiction so that I could share that not only with people who were my students, but eventually be able to share the nature of addiction with other priests and religious, and perhaps not only educate them, but perhaps just enlighten them and perhaps spare some of them the journey of addiction and the pain that I myself walked as a result of active alcoholism. And I'd like to set the context of what we're going to be talking about within the context of the world in which we're living right now, which is a world in crisis. And I don't know if any of you have seen this book or have purchased it yet, but it's a book of reflections by Pope Francis on the current crisis, which was compiled beginning in March of last year and was just published during the summer. And in this book, which is really the result of a series of conversations with a journalist, Francis speaks of the twofold crisis that our world faces now. The global crisis of the pandemic and the uncertainty of just the trajectory this pandemic will take and continues to take. And he speaks also of the existential crisis of every single person living through the current pandemic, that this crisis is inviting all of us to ask big questions. The big question, what's it all about, Alfie? What's the meaning of life, the nature of relationships, as we're trying to be together but alone, isolated. And in reading this book, I couldn't help but think that for those of us living with addiction and mental health disorders, and as you probably have gained some understanding of the fact that usually addiction and mental health disorders go hand in hand, that for those of us living with addiction and or mental health disorder, these things become our personal COVIDs, our moments of crises. And what Francis says in this book, Let Us Dream, is that in every personal COVID, including the COVID of addiction or mental health disorders, what is revealed is the need to change. That the pain of the addiction, the pain of living so long with the mental health disorder, that this is the great motivator to change. And Francis also says that the crises through which we live are crises that reveal our hearts, how loving we are, how willing we are to stretch, how willing we are to grow. So as we talk about the personal crises that every single one of us living with addiction continues to walk, I've been asked to speak a little bit about addiction and recovery in light of continuing care and some of the spiritual principles that I see as informing continuing care and the ongoing journey of recovery. But first, I'd like to make a couple of comments that recovery, as you probably have grasped from the time you spent together already, is a long-term and it's a lifetime process that is not easy. And I look back at my own experience of returning from treatment and how many people in the diocese and in the college, not through any ill will, but simply through a lack of knowledge of addiction, just sort of presumed that life would resume as it did before I left. And that I would be able to come back and work at the same level, the same pace, devoting as much time and energy to the ministry as I had before. Recovery, especially early recovery, is a hard process. Long-term recovery is a process that gets easier and easier as we go through it. But it's also a process, as we'll see, that has its ups and downs. That this journey of recovery that we enter into is a journey, if we're recovering from a substance abuse disorder, that will require total abstinence from alcohol or other drugs, plus active efforts for personal growth, including, in the case of those being discharged from guest house, the work of continuing care. And there are underlying principles and stages, and we'll look at them. They all look very academic, that govern the recovery process, generalities we can make as to what stage of recovery a person might be at. But understanding these principles and naming these stages is never enough. That the understanding of the principles and the stages through which people walk have to be put into action, that there's a lot of legwork that has to take place in recovery. In my case, in the earliest years, that meant meetings of Alcoholics Anonymous 4 or 5 times a week. Things have changed with COVID for a lot of people, but I'm still able to get to 3 meetings a week, virtually or in person. 2 are in person, and the rectory, a group of friends gather. 1 is with guest house alums, but it takes work regardless of how long we're sober or abstinence or recovering from the mental health disorder, that these things take work and require an awful lot of understanding on the part of those around us. That, as one person told me when I was leaving treatment from guest house, one of the great clinicians, your primary job when you go home, quote unquote job, is to stay sober, and that will take work. And these tasks and actions that we need to take place, again, they can be illuminated, we can list them, but they need to be put into practice. And we also want to say that on this journey of recovery, and you probably have picked this up from earlier presentations, it's very natural periodically to get stuck on this journey. So the stages of recovery, just to get into our spiritual principles that I'm going to be talking about here, sometimes a graphic is worth 1,000 words. And in this case, we see that the journey of recovery begins with what we call pre-covery. When, and certainly in my case, I was going through life and ministry as if nothing were wrong. And it wasn't until years later, when people sort of got honest with me after treatment, that they began to remind me of times they sort of like dropped the hint that, you might be having a problem, or you seem to be spending a lot more time drinking than you used to. You seem less engaged in ministry than you were before. So the stages of recovery begin long before we even get to the work of what we're going to see are the steps and some of the other work that we do as part of continuing care. Then there's that process of intervention, which many of you as leadership may have been involved in, where we begin the initiation of the person into recovery. And again, you probably have heard Jeff or other presenters along the way during these 2 days that you've spent together say that we do not need to wait until a person hits absolute rock bottom to get them into recovery. I came to treatment still holding a full-time job at the college teaching and still working in a parish as a pastor. I wasn't at that point where I was the typical quote-unquote alcoholic, unable to work or functioning. I'm not saying I was an alcoholic, but we don't always see the signs that we usually associate with somebody who needs treatment present, especially in those clients that present to us at guest house who are very high functioning people. And then we begin the journey once we get them through the doors and get them into a treatment facility like guest house. The stages of early recovery, which is 3 months. And when I look at my own experience, I was at guest house exactly 3 months to the date. That's summer of 1999. That's just early recovery. The real work begins when treatment ends. And that's not to dismiss the effort that has to be put in on the part of the person rather than the treatment center. But I found the real work began once I was outside of the safety of that treatment center. And then we have long-term recovery, which we say is the mile marker. 5 years in recovery and longer is considered the maintenance stages of sobriety. And this determination that 5 years is sort of the safe point in many ways when we can say a person is at the maintenance stage of recovery. This very much parallels other chronic illnesses such as cancer and other chronic illnesses where medical professionals will say if a person is in remission 5 years, we think that we can safely say that they are in a good point of maintenance steps. And the American Society of Addiction Medicine uses that same time frame for recovery to say they're 5 years abstinent, 5 years not engaged in the addictive process, such as gambling or internet addiction, that this is what we sort of call the safe point to say that the person has transitioned to long-term recovery. So these are the stages that you can read afterward as well as I can. That stage that, pre-recovery where the person is active in addiction. There are very few adverse consequences as a result of their use of a substance or engaging in a harmful process. Very few signs of a mental health disorder emerging. At stage 1, once we get them through the door of a treatment center and begin the journey, as people clear up and begin to detoxify, people begin to realize that there's a problem related to alcohol, drug use, or some process addiction or some mental health disorder. And the goal is to try to instill within the person, in the case of substance abuse, a commitment to remaining abstinent. Then the stabilization phase takes place as people begin to physically and emotionally and psychiatrically recover from some of the damage that's been done to them as a result of the addiction, the use of alcohol or another drug, constant engagement in certain processes. This is the stage where if a person is relying upon medication-assisted therapies, that we begin to see some improvement between 3 years to a year. So the recovery process is not simply a matter of detoxifying a person in the case of substance use disorders. This phase, the recovery phase, takes place over several years. In early recovery, we begin to get people focused on sobriety-centered thoughts, feelings, and behavior. Try to distance them from people, places, and things which might lead to relapse, which you have spoken about in your time together. In this middle stage of recovery, a pivotal phase, that a lot of the lifestyle damage caused by the addiction begins to be repaired. Relationships with people that we have been estranged from as a result of our addiction, these things begin to find some healing and some peace. In later recovery, we look more deeply at family of origin issues, which might not totally absolve us from drinking or drugging or entering into a process to say that we had these terrible issues in our families, but we come to understand these issues in such a way that they enhance our sobriety and help us be more loving and more accepting even of ourselves. And finally, this is the maintenance stage when people, certainly in my case, as a person who's sober several years, continues to work with the sponsors, go to meetings, try to be of service, sponsor people when I can, at least on a temporary basis, they can get the sponsor they want. But this maintenance stage of doing the things that we did early in recovery, this has to continue in my own experience and in the collective experience of people sober longer than I, if we want to maintain what we have received, the gift that we have received, the gift of recovery. In so many ways, 12-step recovery, in my own experience, very much parallels what Richard Rohr speaks about when he speaks about the movement in all of our lives from order to disorder and to reorder. And that 12-step recovery becomes an invitation to trust in Rohr's expression, deep time, a time that's not measured by a clock, a time that's not chronological, a time that is at a very deeper level, that recovery takes place in God's time. So we look at these year markers, 1 to 2 years, 3 to 5 years. That can very much vary from person to person. Nobody necessarily walks through these stages of recovery at exactly the same time by the same calendar markers. That 12-step recovery is an invitation to trust in a deeper time, that this takes place in a time known to God alone. But what is characteristic of all recovery, regardless of the chronological time frame it takes place in, and the spiritual awakening that occurs, is this movement from order to disorder, when our lives seem to fall apart because of the addiction, to reordering. When we look at continuing care at guest house and how we help patients, clients after they leave us, guest house realize that important to what has begun on our campus, continuing care is what happens following residential treatment and is offered in 3 distinct phases after a client leaves, 3 phases over 3 years. These phases, as a rule, when COVID, we're in a different world, all take place on the guest house campus, when we invite clients to return, and then with many of their peers, if they were in recovery. And these gatherings of several days provide an opportunity for those who have been through treatment to meet with their clinicians, to discuss their progress, to meet with others in recovery in an effort to maintain the progress, the good work that they've done while in treatment. Continuing care was really influential in my life. Again, I went through treatment in Rochester and returned there at 3 intervals over 3 years. The first return was 6 months after leaving. It provided an opportunity for me not only to meet with clinicians who had treated me, it provided me an opportunity to reconnect with people in the community of Alcoholics Anonymous in Rochester. It provided me an opportunity to meet with new clients and for them to learn from the experience that those of us who had gone before them had, and for us to sort of be able to encourage them in their journey as they sat in the seats that we sat in before. Continuing care at guest house before the client is discharged, really the work of continuing care begins. That near the end of residential treatment, which varies in the amount of time depending upon the person. And this allows the sister or the priest or the brother or the deacon to share experience and needs and commitments of recovery with others in his or her community, diocese, parish, and ministerial life. It's during this time of therapeutic leave that the client will also meet with what we call a support team, influential individuals in that person's life who will offer support as the person returns to ministry. Part of continuing care is an effort on part of the staff and the client to make known to leadership exactly the type of ongoing support that will be needed. This will include not only work with a support team after discharge, but this will also include appointments that need to be made with medical professionals, other appointments that need to be made for other services that the patient being discharged will require. The ongoing support of 12-step communities, usually during the therapeutic leave. We invite, in the case of those living with a substance use disorder, a person to identify a 12-step sponsor that he or she will be working with. And then also part of our continuing care effort is scheduling of a re-entry visit with the parish or religious community. And this allows the client and the therapist who comes home to this ministerial setting to assist with a smooth transition and return to ministry. And the wonderful thing about continuing care at Guest House is that although we say it takes place over a series of 3 years with at least 3 visits, return to campus, re-entry visits, our staff is willing to return to a diocese, a religious community at any time, long after those 3 years or during those 3 years, if there are bumps in the road that the client or the community or the diocese feel need to be addressed. So as we said, it consists of visits over a 3-year, consistent intervals over 3 years. And also during those 3 years and long after the 3 years, all of our alumni are offered wonderful support from other clergy and religious who are recovering from many addictive disorders, who gather regularly for seminars and retreats to support each other in fellowship and continuing recovery. Chris will probably offer you brochures, samplings of some of the programs that we do offer during COVID and after COVID. Most of our programming, such as this gathering, has been online, but our alumni gatherings have just been a great support to me during these 20 some odd years of being in recovery. An opportunity just to be with other people who have walked that same journey, an opportunity to focus on the things that really matter in life and ministry and in recovery. So when we talk about the spiritual dimension that is part of every phase of recovery, and certainly during the continuing care phase, that clients are with us and into the maintenance phases, all addictions you're seeing from Addiction 101 yesterday presents itself on 4 domains: the physical domain, the biological, the psychological, the social, and the spiritual domain, a domain that is sometimes forgotten by secular treatment centers. That addiction, as addiction progresses, people become increasingly ill on the physical domain, and we can see certain markers of that. People psychiatrically, because of the dysregulation that's taken place in the nervous system, because of the use of substances or addictive processes, people begin to develop psychiatric symptoms such as anxiety or depression. That as addiction progresses, people become socially isolated and removed from communities and friends. My drinking started out as a very social thing. And at the end of my drinking, I was alone in the rectory, drinking alone, not able to get up to say a Sunday Mass. And that was the day before I went to treatment. And addiction also manifests itself on the spiritual level, as especially for clergy and religious, we begin to feel increasingly removed from God, from community, from the church, from the support that has meant so much to us since the time of our commitment, usually made in our youth. And at the hallmark of all addiction, whether it's on the physical level, the psychological level, the social, the spiritual, is pain. That pain becomes the motivator that leads us or those around us to do something. And what is the pain, the deep spiritual pain that I found from my own experience and the experience of hundreds of our clients that I've been able to work with, and even more alums that I share a fellowship with? What's the common spiritual pain that so many priests and religious entering treatment feel? It's the pain of never ever being able to be a kid, really. Many of us are pretty responsible people, and from the time we were little people, we were trained to be super responsible. And that's what have attracted us to religious life or priesthood, this need to sort of be the adult all the time, to care for others, that along with it, we needed to play. The pain that we needed in our early life to be able to be made mistakes, to allow ourselves, first of all, to give ourselves permission to make mistakes, that we needed to be ourselves and not somebody else. So many of us, I think, had images forced upon us, expectations placed upon us, where we never really felt comfortable being who we were. That so many of the folks that, I know through my experience of working with guest house, and certainly my own experience looking back at some of that work that took place in the later stage of recovery, looking at family of origin issues, I needed to know my mom and dad better, especially my dad. My dad was a police officer, and as he kept getting promoted from patrolman to sergeant, lieutenant, captain, he eventually became police chief in the city, the big city of Springfield. As he got promoted, he'd go back to the dog watch. So he'd be coming in from work at 8 o'clock in the morning, and I'd be heading out to school, and never really knew him. Or if he worked the 4 to 12 shift, I'd be coming home from school and he'd be going out to work again. So that relationship with my dad was always a thing that was problematic for me. And it wasn't until I got into recovery that I could begin to address it. I needed to be more comfortable with my sexuality. Certainly people my age and older, maybe somewhat younger too, that sexual orientation wasn't a thing we talked freely about. And for so many of our clients, the ability to talk freely about their sexual orientation, what it is to be gay or straight, is something that did not happen until the day that they came to treatment. It's that process. What's other pains that we share and lead us to treatment? The pain of the formation system itself, especially those of us who went through formation 30 or 40 years ago. We look back at that experience and realize it wasn't exactly the healthiest environment for us to be in. That many of the formators themselves had many issues which they were dealing that became clear to me only after I was ordained. That just made for an unhealthy environment. The pain that we knew in religious life in seminaries of constantly being judged and usually being judged harshly. The pain of unworthiness. As I was sharing with the men on the retreat that I facilitated last week for guest house alums, the bishop under whom I entered the seminary, his final words to me on the day that I left to go to the seminary were, remember that you're helpful, but you're not necessary. That trying to, put humility or just the priesthood in its perspective, but that was the constant message. The pain of favoritism. Many people coming through treatment talk about that and the pain that they've lived with for years because of superiors who favored certain people in the community, bishops who favored certain priests, to the point of being hurtful to others who felt less than. The pain that we felt entering religious life many years ago when we were suddenly removed from family and friends and support system. The day I entered the seminary, the rector stood and told the parents as we were gathered there with them following an opening mass that you've done your job, they belong to us now, so don't be calling here all the time and you'll see them at Christmas. And for many parents, especially for those of us who are younger in college, that was absolutely traumatic. And we live with that and bear some of that pain along into our adulthood. The pain of loneliness and the pain of isolation, and the pains that we know today, the pain of uncertainty in a broken church, always waiting for that next shoe to fall. And all of this is a pain that comes from and often compounds anger. I'm sure many of you referring people to treatment have found that by the time that person gets to treatment, there's a lot of anger accompanying the addiction or the mental health disorder. And if we listen to the words of Marcel Proust, as I said earlier with one of the slides, that pain is something that we must listen to, that pain becomes the motivator usually. The pain the individual is feeling or the pain the religious community or diocese is feeling to get the person into treatment. And so often, the longer we're sober, the longer we're abstinent, the longer we're working continuing care, the longer we realize that a lot of that anger that we had, that we were experiencing, that we couldn't even name, was really grief. Grief at all of those things that we had experienced, needing to be a kid, not knowing my mom or dad, favoritism in the church, that a lot of our clients coming into treatment and months into treatment really are living with a profound grief. And the steps of Kubler-Ross are really steps that we need to walk during the treatment process. You know, the steps that we begin with denial and anger and bargaining, depression, and finally acceptance. So at Guest House, we rely heavily upon the legacy of Bill Wilson and Bob Smith, the co-founders of Alcoholics Anonymous. Austin Ripley, the founder of Guest House, was a very early member of Alcoholics Anonymous and a personal acquaintance of Bill Wilson. And in the Guest House archives is correspondence between Bill Wilson and Austin Ripley at the time Guest House was being founded, because Austin Ripley was being very cautious as a member of Alcoholics Anonymous not to confuse 12-step programs with any particular religion or sect or denomination. That at the heart of the principles are AA is the commitment to be spiritual but not religious. And Bill Wilson wrote back and said that as long as you're conscious of that distinction and work very hard not to confuse the two, I see no reason why 12-step programming and 12-step spirituality should not inform your treatment program for priest and religious. So the whole program began just as a result of a chance meeting back in 1935 with Bill Wilson, who was on a business trip, wanted to stay sober, felt the only way to do so when he was getting compelled to drink after the business meetings was to talk to another alcoholic, a woman named Henrietta Seibling, put Bill in contact with Dr. Bob Smith, who was also struggling to stay sober, a physician practicing in Akron. And these three developed over a period of their friendship of many years, three discoveries that underlie what we're going to see are the steps of recovery and the spirituality that informs Guest House recovery. That the spiritual connection was there. And this was made largely by contact that Bill Wilson himself had with Carl Jung, who believed, after treating several alcoholics, that one cannot recover from alcoholism except by some sort of spiritual conversion. And this led many people to find help in a movement, a reform movement based on principles of enlightenment, which were very common in the 19th century, called the Oxford Group. And they discovered very soon that the malady of addiction is attachment and the solution is detachment. Spiritual principles that inform the work of the great mystics, that inform the work of certainly the Ignatian spirituality. So much of our own spirituality as Catholics is informed by this very simple dynamic of attachment and detachment. The second thing they discovered was the need to carry the message. And thirdly, the importance of telling our stories. These are the principles that underlie 12-step recovery, that there's something spiritual about this movement from addiction to recovery, that we have this need to carry the message to others and through service, and thirdly, the need to tell our stories. Recovery is very much narrative-based. And at Guest House, after a client sits there and is with us and has the opportunity to benefit much of our programming, it's just wonderful to be able to hear them be able to tell their stories in freedom, perhaps for the very first time. And these were the principles of the Oxford Group, obviously dated in some of the terminology that informed the steps. So the Oxford Group spoke of foundational principles And they listed these in terms of a spiritual malady and the spiritual solution. The spiritual malady being attachment and the solution being detachment. So this is the malady and this is the solution that we see, spiritual principles that underlie the journey from addiction to recovery. And we see these finally take form as a result of the work of Bill Wilson and Dr. Bob Smith in the formulation of the 12 steps of Alcoholics Anonymous, which moved from an admission of powerlessness and unmanageability to that 12th action step where we are able to pass on what we have received and share it with others. And these are the steps that inform much of the treatment process and the journey of clients with us at Guest House. And these steps are accompanied by principles. Each of the steps invites us to embrace and to live more fully certain spiritual principles, which we see here. I often say that, despite the fact that I spent so many years in the seminary system, 6 years in the seminary, and later back doing doctoral work, 4 more years in a Catholic university setting, taking all sorts of courses in ascetical theology and spirituality, being at Mass every day, praying in the office. These principles were things that I never really grasped. The simple things, attachment, detachment, until I came through the doors of Guest House and began to really see these things with a clear eye that recovery alone gave me. So what is the spiritual solution about? It's about a movement that these steps take us through, in 12 steps, 4 movements, from first of all, an awareness of my addiction or the mental health disorder that was causing me a problem. Sometimes when we force people to admit that they have a problem, we're doing so a little bit too quickly. They're not even aware of the fact that they have a problem with alcohol and other drug, a process they're entering into, or depression or anger that they're living with, that the illness itself, the changes just in the neuroregulation and the neurocircuitry that's been affected by long-term use of an addictive substance or an addictive process, or the depression itself, has impaired their ability to be even aware that the problem is there. And the next step that we move to after awareness is there's a second stage of admission. The person being able to have enough clarity to see the problem and then to admit to the problem. So there's a lot of work that needs to be done, preparatory work, before we even invite the person to embrace the first step of recovery. And admission usually comes at a stage early in recovery, when we haven't had a chance to understand the many ways in which our alcoholism, our addiction has impacted others. It usually comes at a very early stage. That admission moves eventually at a deeper level to acceptance of what we've met, to being able to embrace fully the reality of what it is to be a person living with a chronic disease, in my case, called alcoholism. And then once we have entered into the acceptance process, embrace that, and this takes place not in a matter of months, but in a matter of years, we are into the action step of handing on to others what we ourselves have received. So you can see the parallel here, an awareness that even precedes the 12 steps, the admission that begins with step 1, the acceptance that begins to take place as we continue to work these steps through prayer and meditation, and then the action steps of giving it away. From step 1 right into step 12, there are spiritual principles guiding our recovery. And as Richard Rohr says so well, our healing and our maturing always begin with acknowledging what's there. And so much of at least the first month in treatment, long before we put a big book into a person's hand and say, begin working the steps, it just takes time to explore what the reality is, becoming aware of the nature of our addiction and the way it's impacted us and the way it's impacted those around us. And as I say so often, it's the broken pieces of our life, of my life certainly, that have become my greatest teacher. And this is why we look at those broken pieces of our life. This is why we look at where our addiction or our mental health disorder has brought us, not to make us feel worse, but to see that God is already present in those broken cracks, which become themselves the invitation to heal. As Rumi says, the wound is the place where light enters our heart. And as we sort of come to an end of our time together, I know this is just a rapid overview of continuing care and the spirituality that informs not only continuing care, but all of recovery. I just want to come back to that first assertion that we made at the beginning today, that none of us thought on the day of religious profession or ordination that we would be living with a chronic addiction, a lifetime disorder, or that we would be suffering and living with mental illness and recovery from it, perhaps with God's grace. That all of us made commitments many years ago without having any way of knowing where they would lead us. And that's Mary Catherine Bateson in her essay that I use every semester with seniors about to graduate, Composing a Life Story, who says this. Her claim to fame is that she's the daughter of Margaret Mead, the great anthropologist. And again, those days of profession and religious commitment were days when we thought that, everything was going to be wonderful, that, that this was just going to be a breeze. But the reality, at least of my experience, is that addiction and there's other roadblocks along the way to become invitation for God's grace in our life. And what the wonderful work of Guest House helped me to do by the summer I was there, being with 35 other men beginning the stages of recovery, to quote Pope Francis in his book, Let Us Dream, that we realized in this process, or I realized with the process of 12-step recovery, that all of us are in the same boat, that we are all fragile and disoriented. And it's important for all of us to row together, each of us in need of comforting the other. And again, this is the great support that I find through continuing involvement with the Guest House family. And again, the object and goal of all spirituality, including 12 spirituality, is the same: union, love, aliveness, soul abundance, service to the neighbor, and service to the world. The 12th step summarized right there. This is why we do what we do each day. And just a final word here, since so many of you are in leadership, the healing process that a client goes through at Guest House invites leadership to its own healing process. As I said, so many of those issues which surface in treatment, so much of that pain that the brother or the sister or the priest has been feeling for years, many of it is directly attributable to early years in formation. And although current leaders may not be the formators directly responsible for an awful lot of what happened to the systems that existed, current leadership in its own way often have to step up to the plate and at least recognize and allow the person about to re-enter ministry after treatment to voice that pain and to find some healing through you who are representatives of that community and that system or that structure in which they found so much pain. And Miroslav Volf, who is a Serbian theologian teaching at Yale in Connecticut, speaks about the process of healing, not only between individuals, but between nations. And he said that this process of healing with the individual who has come to treatment, usually a brother or sister or priest quite unwilling, with a lot of anger toward leadership, that the process of healing begins with a mutual opening of the arms on the part of leadership and the individual to the possibility of reconciliation. And as Wolf says, and I can't quite do it here because it's not live, but When both parties open our arms toward the other, we make ourselves very vulnerable. We expose our heart and all of our vital organs. And that opening of the arms is a gesture of vulnerability, willing to become vulnerable and willing to take the risk of the embrace. The second part of what Wolf calls the drama of embrace is waiting. I can open my arms as leadership to the person who is coming home from treatment. The person coming home from treatment can open the arms to me, but we have to wait to see if the actual embrace is going to take place. It's not necessarily our gesture of reconciliation might not necessarily be accepted. The embrace itself takes place with the closing of the arms, which we see in these images here. But that closing of the arms, that's not where it ends. That we have to reopen our arms and allow the person to be himself or herself and to go on with life in ministry. That people returning from treatment often have wonderful and new insights into life, into themselves, into ministry. That people coming home from treatment have an awful lot to teach leadership. And we need to let go of that embrace. We don't need to hold on to or cuddle over people who are coming home. We need to assist them and accompany them, but we need to open those arms to let them be the person that God has called them to be, unique individuals. Just my final word here, it's my conviction that transformed people transform people. Again, borrowing a lot from Richard Rohr, who himself not an alcoholic or addict to my knowledge, but has a deep understanding of this dynamic, certainly from the perspective of myself who is alcoholic, that this is the miracle of why 12-step recovery and 12-step spirituality work, because of the transformation that takes place, because of my connection and my intimate relationship with other people who are in recovery, that this is where the magic plays. And people who return from treatment transform leadership awaiting them. They transform people in ministerial settings. That our alums do great things for the world and the church, I believe, because of the spiritual foundation and the continuing care that we offer them over a lifetime at Guest House. And I'm going to stop here. We have a few more minutes, and I will turn the screen back over to Chris.
Absolutely beautiful, Mark. Thank you, friend. All right, and you are all welcome to come on back on the video, as well as if you could keep your microphone muted unless there's a question, but I'd prefer if you could use the chat feature to type in any questions, and you can either send them to me directly or to everybody, and then I'll ask Mark or Mary Jean to answer your questions. And then I know at the very end, Mary Jean has a few closing remarks that she'd like to share with everybody as well. So just looking for any chat questions you may have. There is one that came in, Mark. What is the definition of early stage of recovery and the length of time?
I think that might have come in before the slide was up there. It's one of the slides that came subsequently. Early recovery, in my book at least, is like the first 3 months following discharge, in my own experience.
Yeah.
That really what we're talking about is stabilization. When we get a person into treatment, then early recovery is not that 3 months to a year after discharge. And again, these numbers vary for people. This is like deep time that Rohr invites us to look at, but clinically, many people seem to fall within those markers.
And if I could just add a piece here, the women we have more women with compulsive overeating or the process addictions or the mental health issues. I think we started that program before the men started it, so we've had some experience with it. And the continuing care, those women usually come back 4 to 5 times in a 2-year period. We find they can go home and do really well for about 3 months, and then they start to lose it. Because of course, if it's food, you have to eat food all the time. I mean, you have to eat. If it's gambling, you have to handle money. And certainly if it's any of the other disorders, they're with you all the time. They're not quite as clean that you can say, put the cork in the bottle and don't touch the alcohol. Now, I'm not saying that's easy to do. It's just more direct. And so we found that people were really getting into relapse with these other conditions around the 3-month mark. So that's the one thing that's different. The people with alcoholism do well, as Mark has described. They usually come back 3 times.
Any questions for Father Mark or Sister Mary Jean?
Well, we're waiting for questions. If there are any, I've asked Colleen also to send you a copy of the poem that's written by a Cuban poet. It appears in the book Let Us Dream, and the title of the poem is Esperanza. It's translated into English, and it speaks to the COVID crisis, but I certainly think there are parallels there for those of us living with addictive disorders or those who love and care for them. And again, I don't work for the publisher, but if you want to treat yourself to a great read within the next few days, Let Us Dream by Pope Francis really spoke to me. And I saw the parallels all the way through to addiction.
Well, if there's no questions, then you get another half an hour of your day back. And with that, I would ask Father Mark if he'd be kind enough to offer a closing prayer.
You know, why don't we do this? Why don't I pop up the prayer so that people can see it, and I'll just read it. We tried to do everybody's mic open and it didn't work too well in the men's retreat, but I'll just read the prayer that you'll be getting. And again, this is by Andres Villiers, a Cuban poet. When the storm is past and the roads are tamed and we are the survivors of a collective network, with tearful heart and our destiny blessed, we will feel joy simply for being alive. And we'll give a hug to the first stranger and praise our good luck that we kept a friend. And then we'll remember all we lost and finally learned everything we never learned. And we'll envy no one, for all of us have suffered, and will not be idle, but more compassionate. We'll value more what belongs to all than what was earned. We'll be more generous and much more committed. We'll understand how fragile it is to be alive. We'll sweat empathy for those still with us and those who are gone. We'll miss the old man who asked for a buck in the market, whose name we never knew, but was always at our side. And maybe the poor old man was your God in disguise, but you never asked his name because you never had the time. And all will become a miracle, and all will become a legacy, and will respect the life we gain. When the storm passes, I ask you, Lord, in shame, that you return us better as you once dreamed us. And I really think that's the work of recovery in the 12 steps. All will become a miracle. All will become a legacy. All will respect the life that we've gained through treatment, the 12 steps. And when the storm passes, we ask you, Lord, in shame, that you return us even better as you once dreamed us. That treatment and the spirituality of the 12 steps help us to be the people that God always dreamed us to be. Thank you all.
Amen.
Amen.
Well, okay, everybody. Thank you so much for joining us for our Walking with the Wounded. If you have any questions, feel free to follow up with Mary Jean or myself or Jeff. You have our contact information. And if you don't, you can be found at the Guest House website, www.guesthouse.org. And I wish you all a blessed remainder of your day. Thank you so much for joining us.
Thank you all.
Bye-bye.
Great day.
Bye. Very very helpful.
Great. Thank you so much. I'm now going to end, so you're all going to disappear. Have a great day. God bless.
Bye.